only 15 to potentially 40% will present with that picture. 15 to 40%. Which means there's a good number of patients that will not look that way. So you have to know what those presentations are. How about your atypical pains? Look at the top bullet. Musculoskeletal, positional, or pleuritic. Tell me if you've ever seen this either in a hospital or in a pre-hospital environment. I'll draw from my pre-hospital experience because I see it every day. Paramedics walk in, start to evaluate the patient. I'm going to use you, sorry. Is this where your pain is? Does that hurt when I push on there? Take a deep breath for me, in and out. Does that make the pain worse? Hey, if you move around, what are they trying to do with that line of questioning? Trying to determine whether the pain he's having is muscular in nature, or maybe it's coming from movement, lung function. And we have it buried in our head that if we get positive response from that, there's no way it can be cardiac. I'm going to tell you right now that is false. ACS patients can present that way. Don't get tripped up in that. Or you've got a patient that it's not centralized chest, it's either to the left or the right. That could be potentially an ACS. You have to go further. How about this one, sharper stabbing? We many times don't associate that with cardiac pain, but it can. And then this is a big one. I feel gassy. That's not my chest that hurts, it's not my belly, it's right in between. And you know what? I burp and it makes it feel better. What's the predominant MI we see in the field that causes that? Inferior wall, why? You think about it, the bottom of your left ventricle sits on top of your diaphragm. And it radiates discomfort to the epigastric area. Don't miss that. Don't pass it off as, hey, it's just a gas problem or it's a GI disturbance. That's very common. And remember, your female patients often present atypically. They won't have the classic presentation. It may be shoulder pain, back of the neck. I had a guy a number of years ago, and this is way before we were doing 12 weeks in the field. We walked in and he's rubbing his lower back. Oh, my back is just killing me. The problem is, he always has back pain. He's got a chronic back problem. And when asked the question, does this feel like your normal back problem? Yes, it does. Guess what? He was having an MI. That was his presentation. There's going to be some oddities out there. Always keep alert. Make sure you ask the right questions. And then if that list wasn't enough, how about this one? Anginal equivalence. How about the subset of patients that do not have chest pain at all? Their major complaint is, I can't breathe. Which patient is that? Who can tell me? Your elderly population, 65 and above. When they have an insult to their heart, it whacks their lungs right away. I can't breathe. They have a decreased sensation to pain. And you maybe think you're dealing with a respiratory pattern, when a respiratory problem, and it's not. It's a cardiac problem. They feel palpitations. They passed out or they feel like they're going to pass out. And then these last two go together. General weakness and diabetic ketoacidosis. Let me paint a picture for you. You're taking care of a 60-year-old female. She's a diabetic. She's been telling you that she's felt nauseated and flu-like symptoms for the last 3 days. You check her blood sugar and it's 564. She is pale. She's diaphoretic. What's wrong with that picture? What's wrong with that presentation? DK doesn't look like that. Many times those patients are missed as, hey, it's just a fluke. Guess what? That's what their ACS symptoms look like. Fluke. So we got to be alert to those patients also. Atypical presentations, like I said, female, your diabetics, and your elderly. Risk factors. Every patient. This is the short list. There are others. What's the number one risk factor for coronary vascular disease? Diabetes. Diabetes, number one. If you don't know this, you should. In the United States, we have a major problem with obesity. Our diagnosis of diabetes in the field is it's phenomenal. Now we have school-age kids being diagnosed with type 2 diabetes due to sedentary lifestyle, no exercise, poor nutrition. And if we don't get a handle on that, think of what's going to happen to our cardiovascular type presentations you're going to see. They're going to skyrocket. Okay? So we need to do better education when it comes to patients as well. Increasing age, increasing risk. Kind of goes without saying. Just a side note about chronic versus unstable angina. This is where I typically stop and ask the question. You've all encountered patients that tell you, hey, I have angina. I take this little white heart pill when I have trouble. Who can tell me how they come to the diagnosis of angina? How does that work?
Pain's brought on by a predictable level of exertion and response to treatment consistently.
So that's the symptomology. What I'm looking for is the diagnosis. How does a doctor diagnose a patient, you have angina? Where does it come from?
Rules out all the other, rules out stemming, rules out heart attack.
So basically, they've got coronary vasculature that is plaque-ridden. So when they exert themselves, or they get excited, their muscular wall does not respond very well. Many times it may spasm down, and all of a sudden they start to have symptoms. So what's the fix to that, other than giving them pills?
Exercise.
You can do bypass surgery. Some patients are not candidates for bypass surgery. They may stent them. There's options. So you may encounter a patient at home that's been diagnosed with angina. They've been given these pills. They're either waiting surgery or waiting bypass, or maybe they're not a good surgical candidate, and that's their only option. So the reason I'm bringing this up is, you encounter a patient, they tell you, you know what, this feels like my normal angina. Although today, you're seeing something different. Normally, I pop one pill and it does it. This time I had to take 3. Now I'm on my 4th pill and it's not helping. This time I broke out into a sweat and that normally doesn't happen. This time I'm nauseated. This time I passed out and that normally doesn't happen. That's more of an unstable angina. We need to be concerned about that, but that might be pre-infarct angina. So just don't blow those patients off if you know them and say, hey, they always have angina, this is always the presentation. Pay attention to the presentation. That might be different. General therapy for ACS. Our general treatment plan. Beta blockers. For a number of years were used in a pre-hospital setting, not so much anymore, so that's somewhat controversial. But as I mentioned before, our treatment and assessment pathways are usually done simultaneously. So let's briefly talk about oxygenation here. That age-old debate, should I put my patient on a mask or a cannula? Does it matter? Let's say you acquire a 12 lead on a patient and they have an extensive anterior wall injury. Very dramatic change on their EKG. You pick up the fact that they're suffering a stent. Do I put that patient on a mask or a can? Does it matter? If you use the guideline up on the screen, if your patient has a normal respiratory pattern and effort and they're set at 95 or above on their own, all that patient needs is a cannula. The more oxygen you give them by mask isn't going to help out their STEMI scenario. Because the body is already doing what it needs to do. Now, obviously, if your patient is experiencing signs of difficulty breathing, air hunger, pulse oximeters that are low, by all means, use a mask in that scenario. Vital signs. I will bet you right now this is not being done. We should be checking manual blood pressures in both arms. Why? It could be different, but why would they be different? They could have an aortic dissection, and guess what? Guess what the presenting symptom for an aortic dissection is? Chest pain. Okay? Not that it's 100% diagnostic, but if I'm checking manual blood pressures in both arms and I note that major difference, hey, that's part of my differential as to what might be wrong with that patient.
How much of a difference is a difference?
That's an interesting question. Our question was, how much of a difference is a difference? And depending on the text that you read, the numbers are all over the place. But typically, if you're seeing a 20, 30-point difference from one side to the other, I would be concerned about that. And then there's another condition out there that will cause a variance that's not related to ACS, subclavian steel, that would cause a variance due to the artery flow. So there's a lot of different things, but again, it's part of your assessment and things that you pick up along the way. And I hate to say it, and I know I'm old school, and all you young guys here and gals, we have a tendency to rely on an automated blood pressure cuff. Why? Because it makes your life easier. But just know that those automated cuffs, more frequently than not, will give you errant values. The art of using a blood pressure cuff and stethoscope are being lost, and it's compromising our patients. So I was one always in the field. I knew the limitations of it. I always made sure I maintained a good manual assessment of the blood pressure during my assessment to make sure I was where I needed to be with my patients. So you take that as you will, but I think that's something that we need to continue and make sure that it's done correctly. And then, of course, we transmit our EKG whenever we can from the pre-hospital setting for early notification. Okay? IV access. If we've identified the fact that we have an ACS patient, multiple lines are helpful, especially for the hospital. If we're going to do nitro drip, that means its own dedicated line. So if we can get 2 lines on our patient, great. Aspirin. Normal dosage range, 160 to 325. Again, we already talked about the benefits of early anticoagulation therapy. Nitro. Nitroglycerin. What don't you see on the list of what nitro does? Reduces chest pain. Hey, they gave me a nitro, my chest pain's better. Nitro is not an analgesic. Is one of the side effects reduction in pain? Yes, it is. But that's not why we give it. we're not giving nitro for chest pain, we're giving it for this. Because it combats vasospasm in the coronary vessels. Now, it's an added benefit that my patient feels better. So the reason I bring that up is we should be using nitro and an analgesic together. Morphine, fentanyl, something else. Nitro by drip works extremely well. In the hospital, we'll do that. In the EMS world, we're somewhat limited. We either give a pill underneath the tongue or we spray it out of a bottle. The problem is, once it's in, you can't take it back. So make sure you're accurate in what you're doing with your patient. Paying attention to their blood pressure. Asking about erectile dysfunction medications that can dramatically impact the use of that medication in a very negative way. Drop your patient's blood pressure. Avoid the systolic drop. We're going to talk about RVI after lunch, right ventricular infarct, and concerns with that. And then morphine as your true analgesic for reduction in discomfort. Some places will use fentanyl. Some places may use other medications. But we usually use that in small incremental dosing to make our patient comfortable. I learned very early on in my career, I mentioned earlier that I was working with some medics from Florida area. I was taught something years ago from one of the medics from Florida that I will never forget. If you're treating an ACS patient that's symptomatic having chest discomfort, here's what he said to me. By the time you deliver them to the hospital, your patient should be in la-la land. When he first told me that, I was having a hard time grasping with that. Do you know what he meant when he said that? Can you tell me? We need to make our patients comfortable. One dose of nitro or one dose of an analgesic, dropping their severity and pain-wise from 10 down to 8 isn't enough. Our goal should be 0. Sometimes we get there, sometimes we can't. Sometimes we have concerns with blood pressure. But sometimes I don't think we go far enough. We give one round of meds, throw them in the back of the truck, and we move on. And I learned something from that. And it's something that I've always maintained when I treat patients. Take it to where you need to go with all the parameters around it. And then beta blockers, I know this is used more in a hospital setting. Beta blockers are strange in that beta blockers help with the incidence of cardiac arrest. They don't know why, it just works. So for a while there, they thought, well, why don't we give beta blockers sooner? Let's do it in a pre-hospital setting. Well, they found that if you don't use those correctly, because they have major blood pressure effects and perfusion effects, and especially if you're giving it the wrong kind of infarct, you can actually cause damage. So we used to carry them for a short period of time. We disbanded that, got away from it, in preference of more of a management at the hospital level. Is there anybody here in the EMS system that's using beta blockers? No? So let's finish this module up with this case. Find it on page 16. You have a 68-year-old female. Look at her presentation. Anxiety, restlessness, can't catch her breath. No chest pain. She has a history of insulin-dependent diabetes mellitus, diabetic, hypertension. Vital signs are listed for you there. What's your major concern out of this? Blood pressure is slightly elevated. Pulse ox, she's already on a cannula, and she's only statin at 88%. So there's a lot of things we have to ask, right? So what do you think of her story? I know this is a 12-week class. I know we're talking about cardiac, and it's kind of hard to separate it. But if you walked into this, would you be thinking cardiac with the initial presentation? you're probably thinking respiratory, right?
Respiratory, possible panic attack.
Respiratory, anxiety, panic attack. So you acquire a 12 unit, you do your due diligence. And let's suppose for a moment that this is her 12 week.
Does she have a history?
Does that 12 week give you any better credible information? What is it? We've got an inferal lateral stem. She's infarcted. So what are we going to do treatment-wise? Let's talk about her oxygen status. Are we going to change anything for her? She's on a cannula. She's sat at 88%. Probably put her on non-rebreather, right? Does she get aspirin?
Sure.
As long as she's got no rule-outs. Now, those patients that tell you, I can't have aspirin because it upsets my belly, that is not an allergy to aspirin. That's a side effect. I don't want you arguing with patients. Some will be just very adamant. Do not give that to me. But I try and share with them, hey, this is going to benefit you. So aspirin, yes. Would we give her nitro?
No.
Yeah.
How long ago was this? Had she had it?
No. So remember, why we're using nitro? To antagonize vasospasm, which occurs with an acute coronary syndrome. Now, is there more information we want later on for an inferior RVI and all that other stuff? We'll talk about that later. But she's hypertensive, and she would get value from that. Would we give her, let's say, morphine? Why not? She's not having chest pain, right? Morphine is an analgesic, but what else can morphine be used for? Anxiety. Again, look at your own internal protocols wherever you work. Morphine would benefit from this patient to getting her into la-la land. So she's going to feel better. So those are the things we have to put together. Story, risk factors, EKG helps define treatment. And when we get to the next module, we're going to build in the next component, especially for my EMS partners here, as destination for these patients. Questions? Is this stuff helpful to you? So we are at 11:25. I think instead of jumping into the next module, which may take a little bit of time, we're going to go ahead and break for lunch. How many of you brought something with you? Or how many of you are expecting to go out? Okay. Why don't you guys be back by, hopefully this gives you enough time, 12:45. That'll give you a little bit hour and 15 minutes. If you want to bring stuff back and eat while we start, that's perfectly fine.